Hello, my name's Kath Bery. I'm the very proud co-author of this medical textbook for menopause, looking at menopause, a complementary guide for practitioners. I'm here with my GP friend, Dr Ute McCrudden, and we're just going to be talking a little bit more about menopause from a GP perspective.
Yeah, so thanks first of all for inviting me to do this chat with you. I feel very honored. So I'm Dr. Ute McCrudden. I'm a GP in Bournemouth on the south coast of the UK, and a big bulk of my work as a female GP is to consult patients that go through the menopause. So HRT is a big minefield, and a lot of my consultations, patients come in, they may have Googled menopause symptoms and their treatment and are overwhelmed, and then decide I better go to see the GP to have a clearer understanding of it. So we as GPs operate under guidelines, and the national guidelines are regularly updated guidance to us in primary care on safely prescribing and sharing treatment options for our patients that come in. Each individual is different, and we have to take each individual as a new patient with their history. It's very important to me that I listen to their story and see what they already know about menopause and about treatment options, and to match their expectations. So that's my first thing. So I will listen, I will try to elicit what the most troubling symptoms are, and then take it from there. So the majority of the patients, I would say, will come in with symptoms, uncontrolled symptoms. They will say, please help me. I have got hot flushes day and night. I feel irritable. Everybody around me, my kids, my husband, are noticing that I am not myself, or work colleagues. I don't sleep very well. I've got brain fog. I haven't had sexual intercourse because I feel dry and it's painful. So those are the classic symptoms patients come in with. So like on each individual basis, then I will go with them through their personal history, their gynecological history, their age. What have they tried already? Have they already tried anything over the counter that is available? What would they like? Do they want to have some generic information, go away and have a think about it? Or sometimes it happens they come in and are desperate on that day actually to walk away with a prescription of hormone treatment, because they have actually suffered for so long and already waited for a long time to get to this point where they come and see us. So it always depends on each individual situation. Then I would, after I have listened to what their personal history is and established what their main symptoms are that is troubling them, I would then go through the HRT options under the national guidelines with them. So HRT options in a straightforward case for us patients in primary care would be classically a woman will come at the end of her reproductive years, late 40s, early 50s, with symptoms, and is asking to have hormone therapy. So then we have to establish, is the patient, when was the last menstrual period? Are we safe at that stage to start hormone prescribing? We do need to advise patients to initially have a blood test, just to get a general blood test to check thyroid hormones and the kidney, the liver function test, full blood count. And after that, we can start hormone therapy. Some people are put off by that, but the blood tests generally don't take more than 4 or 5 days to come back. So there's not a significant delay in starting therapy for these women. I keep it simple because the information you get online is so overwhelming. So the simple advice is a patient who still has their womb, their uterus, hasn't had a hysterectomy, does need 2 different types of hormone. One is the estrogen, the other one a progestogen. The estrogen, we are now very lucky with kind of the development of estrogen that we now have bioidentical estrogens that are virtually very close to what our own eggs used to produce the estrogen of. So they are the safest type of estrogens. Those are the one we would most likely advocate. The estrogen comes in different forms. It comes in plaster form or in gels or tablets. And the progestogen comes in form also of tablets or a coil. So I will explain this to the patient, and I will say the most bioidentical estrogen would be either in the form of a gel that is used daily, or in form of a plaster, which is a small kind of a sellotape looking translucent square that's put on the buttocks on twice a week on 2 non-consecutive days. It's important always to start a low dose, and after a month I'll phone the patient or bring them back in again to see how they get on. The majority of the patients have a significant benefit already at that point and are actually finding they want to carry on. I have a few that are maybe not happy with the plaster or have an allergic reaction, but it is several consultations until we get it right. But I tend to think once we get it right, it is a really, really beneficial treatment for women that go through the change. And then women who have had a hysterectomy for various reasons, endometriosis or fibroid uterus, for those women, it will only be estrogen. They don't need the progesterone. The progesterone is merely to protect the lining of the womb from building up from unopposed estrogen. Potentially that could lead to problems long-term with endometrial cancers. But this is important that no woman will leave, the kind of consultation with a prescription with the incorrect medication prescribed. Testosterone has only just recently, maybe in the last couple of years, become a hot topic because I think women in the States and Europe and Australia have used it more commonly, prescribed by their GPs. In the UK, it had to be prescribed from the specialty menopause clinic until about a year and a half ago when we got the green light from the menopause clinic to say we can prescribe it. So it's a bit of a myth with the testosterone. A lot of women think it will pick up their energy, it will give them kind of a better general feeling. However, the evidence actually suggests that the testosterone is actually only licensed for low libido. So as long as this is kind of, I have to make it clear in the consultation that it is only literally to treat low libido, and the potential side effect of it long term would be lowering of their voice and also potentially increased growth, hair growth, which is unfortunately then irreversible. So that is something that I just want to make sure that women have a think about before they embark on it, that it is licensed purely for low libido and the potential side effects would be irreversible. So I have prescribed it many times, but only with women's consent, that they take the responsibility of taking it. So you would certainly start the combination treatment first before you would start to add in the testosterone. For that, you would have to do a blood test and add that in the blood test only if women are asking, if they are desperate to go on testosterone. I would do a blood test, check their testosterone level, see if it's significantly suppressed, and then, there is definitely clinical evidence and then to give it. So, but you wouldn't start all in one go for that very reason that you then don't know, is it that or is it the testosterone that has improved overall symptoms, because the estrogen and progesterone can do it themselves. What we also do is if, for instance, vaginal dryness is an overriding symptom that, is a problem during intercourse, in addition to the topical estrogen, the gel or the plaster, we can give intravaginal estrogen. And that does help for kind of lubricant and also to moisturize the vaginal area and make intercourse more possible. Yeah, no, there's no benefit of it really unless the woman is below the age of 40 and they are going through maybe premature ovarian failure. Then you would definitely have to do that. And if you have a woman that goes through very early menopause, then again that would be handed over to gynecology, to the actual menopause clinic to establish why that is. If the natural cycle of menopause is, it can start at any time, 43, 44, or 55. But if a 48-year-old woman comes and says, I haven't had a period for 6 months and I've got hot flushes, there's no benefit of checking their FSH, LH, estrogen, because we know it will be deranged. There would be no benefit to them or to, it's a not cost effective. So many women come aged 45 with regular periods and they do have symptoms menopausal symptoms, the brain fog and the hot flashes. So we do still, we are able to treat them despite still having the regular period with HRT. So it's still possible to treat as long as you have an additional contraceptive hormone if these women are sexually active. So anybody come, as soon as you have symptoms that are troublesome, I would say it is really, help is there. Treatment is there, readily available. We're very lucky in this country that, we can help this kind of cohort of so many women. And I think the earlier you come, the better, for help. It's not for everyone, HRT, but I would be an advocate because I see the benefit, having prescribed it on so many occasions within national guidelines. I would not ever go over, over and above what is under the National Institute of Clinical Excellence advice. Patients don't like taking pills. So number one, they don't like pills. They say, I don't like plasters. I'm allergic to it. And I just don't like to put anything inside of me. So it's very much a patient choice, really. It is their decision. Patients who've had breast cancers, personal breast cancers, or first degree relative with breast cancer, I personally wouldn't start them on HRT. If they still have serious symptoms, I would refer that on to the menopause clinic, or patients that have had any other hormonal serious imbalances or serious kind of past medical histories on multi-pharmacy medications, I'd be more cautious and I would hand that on. But the majority of women that are uncomplicated, the 80-90% that we can help in primary care. I think it's important, for me it is very important, we listen, we take kind of stock and, give all the relevant information individually to what the patient is expecting. So match patients' expectations, inform them they have all the right information, and then be there for this patients group to support them, because often patients have got additional problems. Often they are kind of stuck with having teenage kids and the elderly parents, or go through a divorce and have got other mental health issues in addition to that. And then often it's very difficult to kind of establish, is the brain fog and the panic attacks, and the sleepless nights, is it due to them going through a difficult time in their personal life, or is it compounded by the menopausal symptoms? Or would it be, if they wouldn't have the additional mental health baggage in their personal life, would it be still the same? So this is often a difficult grey area, but I think with a lot of support and women can be very well treated. Their symptoms can be very well controlled, and it shouldn't be such a difficult journey. I do feel sorry when women come at the age of 55, 56 and have left it and have kept on, fighting it. I can do it without, and they can't. And then once you are in that phase of, cluster flushes and that wake you, then it's a lot more difficult than to get on top of treating these women. So I think I would say come for any information as early as your symptoms are kind of getting in the way of life. Lifestyle is crucial in advising patients on menopausal treatment. Caffeine, we know caffeine, alcohol, cigarettes, kind of an unhealthy diet, I guess, lack of exercise, all these things are compounding to symptoms. So we do know that if you are out on a binge drink, you will have more hot flashes, that night. You could say it's the alcohol. You could say it's kind of a combination of menopausal symptoms and alcohol. So we do kind of very much advocate to have a very healthy lifestyle, healthy diet. Look after your sleep, look after your mental health. Exercise is crucial in my view. Anything from yoga, cold water, swimming, cycling, anything that helps to kind of kick in the endorphins and make you in general feel better, it can only be helpful for patients that are struggling to go through the menopausal symptoms.
Thank you, Dr. McCrudden.
Yeah, complete pleasure.
These women that are going to benefit from your sharing your knowledge. It's so lovely. It's so lovely to,
yeah, good.
Because finding good information, having access to good information is really difficult, especially on the internet.
Yes,
so
that's true. That's true. No, complete pleasure. Complete pleasure.
Thank you.
Yeah, nice.